Hi, I'm Meg Callahan with Infectious Disease Special Edition, and I'm here with Hallie Prescott, who's a professor of internal medicine at the University of Michigan, and also the lead author on new guidelines that have just been released on surviving sepsis. And I should maybe qualify, you are the lead author of the adult.
That's correct. Yes, the adult guidelines.
Yes, because there's also pediatric in tandem being released, which is very cool. Thank you so much for taking the time to talk to us.
Yeah, thanks so much for having me, Meg.
We could just start off with what's new about the guidelines that people should know.
Yeah, of course. Great question. It's hard to sort of distill it down to one soundbite. There are 129 recommendations in the guidelines, so, quite comprehensive. And we really made an effort to carry over some recommendations from prior guidelines so that we could answer and address new questions. So in total, there are 46 statements that address questions that have not previously been addressed in prior guidelines. So there's a lot of new stuff. But in terms of what are the sort of hot topics or most important things, I would say the first one is that we have new recommendations related to pre-hospital identification and treatment of sepsis. So the first is a conditional recommendation to screen for sepsis in the ambulance en route to hospital. And the second is, I would say, a very narrow recommendation, but important recommendation to initiate antibiotic treatment in ambulance, very specifically for people who are hypotensive, have suspected sepsis, and have a prolonged transport time, meaning that it's anticipated that it will be over an hour until they are seen and evaluated in hospital. So again, we're always trying to balance antimicrobial stewardship with timely treatment for sepsis. And so this is meant to be a targeted recommendation for really those most sickest patients who have a prolonged transport time. So those are big ones related to the pre-hospital evaluation and management. I would say the second thing is that we see an evolution to trying to be more targeted in the initial empiric antimicrobial therapy for patients with sepsis. Again, really trying to balance timely treatment for sepsis, but also antimicrobial stewardship and, limiting kind of unnecessary antibiotic exposure and complications. And so we have a new, again, sort of conditional recommendations against empiric anti-anaerobic therapy for patients who are at low risk for anaerobic infection. So that's new. And then I would say the third one is that we have a new conditional recommendation for having a lower MAP target of 60 to 65 for older patients ages 65 and up. So those are probably the three, I would say, biggest new recommendations.
Very cool. Specifically interesting about the prolonged transport time. That's very, and it just shows how there's so many different factors. There's so much going on. What would you want a practitioner to take out of? There's so much going on. What would be the takeaway?
Yeah. So I think there are core, fundamental tenets of sepsis care that are unchanged, right? So sepsis remains a time-sensitive medical emergency, and sort of time to treatment of infection and time to hemodynamic resuscitation just remain absolutely sort of key core components. And those are really unchanged. But we want to be sort of nuanced and sort of minimize overly broad antibiotics or, too much resuscitation. But again, sort of timely recognition, timely diagnosis, timely treatment just remains just ever important.
Very cool. Now, when you and your co-authors were deliberating and making these new guidelines, was there any notable moments that you'd want to share that either maybe there was a little bit of disagreement that got resolved, or I don't know, maybe you came to agreement quicker than you thought?
Yeah, of course, it's a great question. Yeah, so one of the sort of, just very cool things about the guidelines is this, just how diverse the panel is. So we have panelists from 23 different countries. So people are coming from this, from very different perspectives, very different practice settings. And we know that sepsis is just, something that's important across the globe and, very different practice settings. And so you can understand that people have sort of different approaches, right, depending on where they come from. So things that I would say maybe are controversial or sort of took a little bit of time to sort of come to the right statement were, I mentioned this recommendation about antibiotics in ambulance or in flight en route to hospital, sort of getting the wording right, so that we really convey the patients for whom we are recommending this, right? It's not everyone in an ambulance, right? But very specifically people who are hypotensive, critically ill, prolonged transport time. So that one took a little bit of time to sort of get to the point where we felt like we were conveying the proper population. Another one is that we have a suggestion to use either invasive or non-invasive blood pressure monitoring, and that's a change from prior. So previously, we had recommended that for patients with septic shock, we recommended invasive blood pressure monitoring with an arterial line. And I would say that there's been a little bit of a general movement kind of away from like invasive treatment, or at least questioning of whether that's always needed. But again, I think that's a little bit context specific, and people have sort of maybe different opinions depending on the type of patients that they typically manage. I think that in the US, we have more intensive care unit beds, so we maybe take care of some patients who are less ill. They come in, they're on very low dose vasopressors, they're off within a couple hours, and then maybe back to the ward. And, we realize that, we can take care of patients like that probably without requiring invasive blood pressure monitoring. But in other places, I think people take care of very, very, very sick patient population. And clearly for patients who are very critically ill, multiple vasopressors, I think it's like the sicker you are, the more justified it is to have more invasive monitoring. So that one had a fair amount of discussion. And then another example I'll give is that we had a question related to liberal versus conservative fluid resuscitation after this kind of initial pragmatic bolus. And for that one, we have trials and they really show kind of no difference between that. And we have this commitment, right? Like if there are high quality trials that address the question that we will answer, we will issue a statement. And so then you're left making this statement, well, gosh, we have high quality evidence, good clinical trials. They show that, outcomes are kind of the same, whether you do either of those. And so you're left with a statement of, well, we recommend either of these things. And I don't know, somehow that just like never feels quite right, And so then, I don't know, you feel like you wish you could go back in time and like change the question, but like, you can't do that either. Of course, we set the questions and we go and answer them. So at the end of the day, I think, it's less, I think my observation is it's probably less about whether this is a liberal or, conservative fluid resuscitation, and probably more important to personalize resuscitation for people with ongoing hypotension and hypoperfusion. So those are just a few examples. It's about getting the wording right, sort of considering really all the different sort of contexts within which we take care of patients with sepsis, and then, trying to sort of figure out how to make helpful recommendations, but also being true to the methods that we've, like committed to use.
It's a lot. So thank you so much for taking the time to work on these guidelines and to talk to us today. Thank you.
My pleasure.
Don't forget to like and subscribe so you can catch everything from Infectious Disease Special Edition.